Thanks for joining us today. Our first question, or my first question, is can you tell me a little bit about how you actually found your way into gynecologic surgery?
Yeah, it's interesting looking back at, being a medical student, trying to figure out what you want to be when you grow up. And a lot of my decision was just the fact that the residents on the OB-GYN service were very bright, very engaging, really took a passion for educating students. And in the operating room, George Morley, who was a senior surgeon at the time, really liked to get medical students involved. And I still remember him asking me to put my hand in the wound and feel the smoothness of the peritoneum. And I think it was that, that excitement about surgery and excitement about getting medical students involved that wasn't true on other services. And that was, I guess, the reason that I kind of navigated towards OB-GYN in the first place. And then surgery was something that, I've always enjoyed working with my hands and fixing things. And so that was just kind of a natural for me to want to have a surgical part to my career.
Perfect. Thank you. The meeting theme this year is surgeons as change agents. How have things changed over the years, and what changes do you anticipate in the upcoming years?
Yeah, I think that in some ways things have radically changed, and in other ways, sadly, they haven't. At least in pelvic floor stuff, we're using operations from about 100 years ago. And even though people say, well, I use this instrument or I use this approach and things, I think that we haven't really embraced the science that's dramatically changed our understanding of what's going on in the last 30 years. That when I came in and asked questions about, gee, what's wrong with these patients, I would get these kind of vague answers about, well, things get stretchy and, you have to put stitches in to fix this or that. And now there's a real scientific foundation that wasn't present in the early meetings that I was at. So I think that it's really an exciting time, especially for young people, because there's so much new information about what we could be doing that I think the next generation will fully embrace and get us onto a more scientific foundation with our surgery.
Yes, it's funny. We have a generation of medical students now also. They're so bright. If you tell them things get stretchy, they also won't accept that as
Good for them.
an answer.
Good for them.
Exactly. We used to just accept what people, told us. So
yeah. Well, and the dominant term back then was pelvic floor relaxation. That's what people called it. And it just kind of covered up the fact that we really didn't know what was going on.
Correct. And it's still a clinical diagnosis that you can actually use, right?
Yeah.
Tell me a little bit about what you think makes a good gynecologic surgeon.
Yeah, I've thought a lot about that. Being older, I have had contact with lots of people over the course of time and admired many of the surgeons that I've met through the Society of Gynecologic Surgeons. The pat answer from the 16th century is the eye of an eagle, the heart of a lion, in the hands of a lady. But I think that there's more to it than just, those kinds of basic principles. I think the first thing that I think is a commitment to be better tomorrow than you are today. That it's, the attitude of an athlete or a musician who's trying to incrementally get better every day of practice, and to think about reflecting at the end of an operation on what went well and how did that do well. And then at the same time to say, if we had a do-over, what would we do over again? In the operating room, that's a question that I would pose to the fellows and the residents afterwards. It's, what would you like to do over if we had to do this over again? And I think the other thing is the dedication to find and identify outstanding surgeons and to engage them in dialogue or visit their units and watch. Video, especially for endoscopic surgery, has allowed people to be able to see what's going on. But I think there's a lot that goes on in the operating room other than what you can see in the surgical field. And I've always found that the opportunity to go and visit somebody in their own operating room and hear from them and learn from them has been one of the things that I think more people should take advantage of.
To your first point, it almost sounds like being a good surgeon is a lifelong process, right?
Right,
It's not just, you become
right.
good and then you practice, right?
Yeah,
It's a
yeah.
practice.
Cullen Richardson, who was one of the founding members of the Society of Gynecologic Surgeons, used to say, you know, John, if I'm doing something tomorrow in the operating room the same way that I'm doing it today, it's a frank admission that I'm too damn stupid to come up with a better way. And I always liked that about Cullen. He was always trying to come up with a better way to do things.
I like that. I mean, it's funny. A lot of people find their comfort zones, right? And we do tend to do
Yeah,
these procedures the way we were taught, and then we innovate a little, and then we just stick with it. But
yeah,
there's a lot to be said for what you just said.
yeah.
Um, Tell me a little bit about what role SGS has played for you in your career.
Yeah, it's changed over the course of time. In the beginning, as a very wet behind the ears junior faculty members, one of the biggest things that I valued was sitting at breakfast with some of the country's most outstanding surgeons, hearing them tell war stories about difficult cases that they did, and how they tried to manage things. And it was really an immersive learning. Um, the science of the presentations in the beginning wasn't all that good. People were very experienced surgeons and talked about their experience, and that's changed over the course of time. I, I think that SGS is a forum for serious surgeons to be able to talk about the craft of what we do is something that I've really valued. And the other thing that I felt very, very fortunate was to have the opportunity to have some leadership roles. I think all of us hope to be able to make a difference, and being chosen to be on the executive committee and as an officer allowed me to be able to give back some to the society for all the things that I have learned from it. And so I think those are kind of the key things that I've always thought about that were meaningful for me with SGS.
Super. Um, well, I can definitely speak to this one as well as all of my contemporaries. I
Uh-huh.
can definitely tell you how we think you'll be remembered, but I'd like to know how you would like to be remembered.
Yeah, yeah. I still think of myself as a 13-year-old boy that's just interested in taking his bike apart to figure out how it works. And I felt so blessed that I've had the opportunity to do that professionally. And I guess the way that I'd like to be remembered is somebody who tried to figure out what was wrong with women in ways that would improve our ability to take care of them. Um, a part of that is the scientific part of what I've done with trying to understand pelvic floor disorders. And I think a part of that is also just the privilege that a lot of us have in training residents and fellows and junior faculty members and things. And I guess that's the other thing is, to be remembered as an educator and somebody who tried to be able to help people develop their skills and in the operating room, and to develop their curiosity about how to answer questions that would have a difference to people later on.
I think one of my favorite parts about teaching this sort of younger generation is
Uh-huh.
connecting what we know to the people who have really been the ones to either discover or put labels
Mhm.
on or innovate on it. Actually, um, making that connection that we have this
Mhm.
knowledge because of the people who have come up with these theories, proven these theories, demonstrated what we know now is really
Mhm.
important, rather than just
Yeah,
telling young people like this is
yeah,
what we know, but actually connecting it to real people. It actually inspires them to decide, am I going to be just, and I don't want to just say just a practitioner, but
yeah,
also
yeah,
am I going to be the person who makes the next discovery? I think is really
yeah,
important. And so I love speaking your name in the operating room, and plenty of others who've really sort of led the way, and really
yeah.
having a creating this understanding, first of all, of why we do the surgeries that we do and
Mhm.
what we're doing when we're actually doing them. So I
Yeah.
know so many of us are grateful for the work that you've done.
Well, and it is, I'm glad that you touch on that, Cecile, because it's so important is that, the things that happen are things that happen because somebody saw something that other people hadn't noticed or thought about these in a way that they hadn't noticed. Papa Nicolau was not looking for a cervix cancer screening tool. when he was working on cervical cytology, that, as I remember, he was just looking at it as a way to be able to look at hormonal cycles. And then in women started to see these abnormal cells. And so oftentimes it's serendipity. Or Cullen Richardson, who was the first one to really call attention to the fact that prolapse happened because of failures at individual sites, had a patient that he was seeing who had a cystocele, and it was one of those cystoceles where there's not bulging, it's just the anterior wall is down. And he knew that an anterior repair wouldn't fix her problem. And so he told her, he said, the standard operation I don't think would work, and I don't know what's wrong with you. So he then went to the Atlanta morgue for a year and dissected, and figured out about the lateral defect, and then came back to her and said, I think I know what's going on. This operation's never been done before, but I believe it will work for you. And if you're willing, that's what I would suggest that we do. It's just those kinds of stories that really enrich what it is that we all inherit from the generations that have gone before. Glad you bring that up.
So well said. Thank you. So this has been fun for me because I always try to predict ahead of time, and there's a generational answer that comes through. But tell me a little bit about what your favorite surgical instrument is and why.
Yeah, I have done a lot of Michigan four-wall sacrospinous suspensions, and there's a modified Duchamp ligature carrier that we use that's much longer than the standard Duchamp. It has a much smaller arc on it and is at an angle that makes it really easy to use. And, it's just the fact that in the process of doing the operation, you can be absolutely certain that you have a bite of really strong supportive tissue. Because once you get it through the ligament, you can wiggle it back and forth and test and see whether that's really the kind of, and if it's not the kind of bite I want, I just dig a little bit deeper or do something else. So I guess I have a fondness for that operation. I know that most people are more comfortable with the Capio these days, but it's only been a tiny handful of cases where I haven't been able to get a Duchamp ligature carrier to work. And I guess if there was one other, it's having a very fine vascular needle holder for fistula repairs. The needle holders that we use in gynecology would flatten the kind of fine needle that you used to use in fistula repairs. And the nurses all knew that I liked the pediatric cardiovascular needle holder from the room next door. So they would always have that for me in the operating room. And it was always a good day in the operating room. As you know, when people know what it is that makes a difference and gets it for you, that's really a big plus.
Going back to your direct visualization and placement of your sacrospinous sutures, I think that also speaks to surgeons' comfort levels with that dissection too.
Yeah.
In order to do that, you have to do a real dissection.
Yeah, I actually don't do direct visualization.
Oh, okay.
I develop the space and make sure with my fingers that it's cleared of the loose stuff that's over it. And then I do it by palpation. Because doing it by palpation, I can tell exactly what the tissue that I'm getting is. Whereas if I learned by visualization, but the problem is that you can't really tell where the tough stuff is. And so I would have my two fingers on the ligament and then run the shot down to where my fingers are. And then I could dig into the tissue with the ligature carrier in order to be able to make sure that I wasn't just getting the coccygeus muscle on the surface, that I was getting the ligament, which tends to be a little bit behind. And so I know that a lot of people who are doing it the way that I did it 20 years ago feel that if they're using a Duchamp, they have to visualize it. But I hadn't done that towards the end. And I would just, once we had the Duchamp in, I just take a narrow malleable and slide it down the shaft of the Duchamps until it hit the hook. And then I just jump over the hook. And that way I could see the suture. Just pull it with a nerve hook. So
So it's similar actually to the technique that individuals are using, the Capio or other deployment, suture
Yeah.
capturing devices. It's just using
Yeah.
that particular instrument. I'm assuming you're actually probably getting a much better bite and a much sort of thicker placement of that suture. Those Capio devices don't always get a really great secure bite.
Yeah. Well,
Especially if your trainees are placing them,
Yeah.
So.
Well, and that's I think part of the evolution that we were talking about
Yeah.
before with surgery, is that I had some times that I put a stitch in, and then as I was tying up the vagina, it didn't go all the way up, and I realized what had happened is I'd gotten the loose stuff and not the tough stuff, and so 10 years afterwards I learned that. 20 years afterwards you learn another thing, and so it is an evolution.
It sure is. I even got a surgical tutorial out of this interview. The individuals editing this will also benefit.
Yeah. Well, and all of us love talking about what we do in the operating room. I mean, it's just a part of being a surgeon.
It's fun, right? The concepts are all similar, but we come from all of these different training backgrounds. It's fun because I get to, I'm interviewing Bob Scholl soon, and I do my uterosacral suspension technique is his, because Mark Walters trained me. So, but I've never spoken to him. So it's going to be really fun to get to chat with him a little bit,
Do you know who first described that operation?
Beforehand?
It's in 1926.
No, tell me.
Norman Miller.
Norman Miller. I would not actually have guessed that. Mark would be ashamed of me for not remembering that. He's taught me a lot of gynecologic history. So,
well, I think people don't know that he was. I'm the Norman F. Miller Professor of Gynecology, and I was just reading Dr. Miller's articles just to kind of familiarize myself. And here's this beautiful article from 1926 with all of these fabulous illustrations about high uterosacral suspension. And it obviously disappeared from people's writings and things. And then actually Bobby started it after Cullen Richardson started doing uterosacral suspensions with a guy named Bill Say, who was Bill was a gynecologic surgeon who was the first person to do a laparoscopic cholecystectomy.
Okay.
He had a general surgeon in the room.
Interesting.
But the general surgeon didn't know how to operate laparoscopically. And Cullen and Bill started working together because Bill had all these laparoscopic skills. And so Cullen would tell him where to put the stitches, and they would put them in the uterosacral ligaments and then suspended that. And then Bobby said, you don't need to do a laparoscope to do that. You can do that transvaginally.
Well, now we're coming full circle and people are doing it laparoscopically through the vagina.
Right.
I won't ask you about your thoughts.
Yeah.
I won't. We're still recording, so I won't ask you about your thoughts. I want to thank you so much. This is great. I really appreciate you taking the time, and I know, going through the questions and reading them beforehand, and I'm just appreciative of you, and getting to spend 17 minutes with you has made my day. So